This lecture is going to discuss gastric cancer. This will mainly follow the SCORE module objectives for resident education with some variations as well. So a brief word on anatomy of the stomach needs to be understood and discussed to understand how we manage gastric cancer. For the junior residents, the top of the stomach is called the fundus. The part just beyond the GE junction is called the cardia. The body is the majority of the stomach, and then the antrum. When we talk about proximal and distal gastric cancers, essentially anything beyond the cardia and the fundus is considered a distal gastric cancer, and that's mainly because we have to get a 4 centimeter margin when resecting a gastric cancer. And so in order to leave any sort of meaningful pouch up top and to do a subtotal gastrectomy, we have to be at least 5 or 6 centimeters away from the GE junction. So when you're talking about a proximal gastric cancer, it's anything kind of within 5 or 6 centimeters of the GE junction, which requires a total gastrectomy. A distal gastric cancer is, body down, and that can sometimes be treated with a subtotal gastrectomy. The other important things about the anatomy of the stomach are the layers. So the mucosa and submucosa, we'll get into this on the next slide, but 2 layers of muscle in the proper muscle of the stomach, or the muscularis. The other important thing to know about the anatomy is the layers of the stomach. So you have the mucosa, submucosa, and then you have 3 separate layers of muscle in the muscularis, and then the serosa covers the stomach on top of that. Again, we'll talk a little bit about lymph nodes later, but basically there are lymph nodes on the left and right of the cardia or proximal stomach, and then lesser curve nodes, greater curve nodes, and then supra and infrapyloric, so near the end of the stomach, above and below. So the other important part of anatomy that I just mentioned is the layers of the stomach wall. So the mucosa, which really consists of what you'll see on endoscopic ultrasound especially, is the muscularis mucosa, which is just inside of the submucosa. The submucosa, I'll show you a picture of an endoscopic ultrasound, but it appears white on ultrasound. And then the muscularis proper, which is going to be a thick black band on ultrasound, and then the serosa will be a white layer again. So mucosa and muscularis mucosa, black, submucosa, white, muscularis proper is going to be the thick black band, and then the serosa outside of that. This is important because depending on how deep the tumor penetrates, that's going to determine your T stage, and in a lot of ways determines the management of the gastric cancer. So we'll focus in on these layers and look at a picture of endoscopic ultrasound. So again, here we see endoscopic ultrasound. This is the probe, and then we see the layers of the stomach wall here. So as we label these, this first band right here, this darker band is going to be the mucosa with the muscularis mucosa contained within that. This next band here is the submucosa. Again, it's going to be a white band. The second band, white band. The actual mucosal layer is this kind of thin white band, but we don't worry so much about that when we're talking about staging gastric cancer. And then the next dark band is going to be the muscle layers, or the muscularis propria, or the proper muscularis, whatever you want to call it. And then beyond that, you're going to have some subserosal tissues, and then eventually you'll have the serosa. And again, this is important mainly when we start talking about the T stage of the tumor, which is generally decided by endoscopic ultrasound in the setting of clinical staging. So the epidemiology of gastric cancer, kind of things we need to know. Gastric cancer is more common in East Asia, South and Central America than in Western countries. Globally, it's the 5th most common cancer and 3rd leading cause of cancer-related death, but in the United States, it's the 15th most common cancer and 15th leading cause of cancer-related death. So it's actually a fairly rare cancer in the United States, but more common in other areas of the world. For instance, in Japan and Korea, it's actually the #1 most common cancer amongst men. So extremely common in Japan and Korea, also in China, a little less in South and Central America, and much less common in Western countries. So Most gastric cancer is going to be adenocarcinoma. So really, that's what we're going to focus on here, is just talking about adenocarcinoma. There's a very meaningful histologic distinction that we have to kind of get down, and that will shade everything you do with gastric cancer. Really, is diffuse type versus intestinal type. So the diffuse type is the worst one, the one you don't want to have. Undifferentiated cells in a scattered fibrous stroma. Fibrous stroma in general in cancer is bad. Think pancreatic cancer, which has a very fibrous stroma. And these cells, again, they're more scattered. They tend to creep up away from wherever you think the tumor is. It's harder to get an R0 resection on these patients because these cells kind of creep up and down the stomach wall. This is more common in low-risk areas like Western countries. So in the United States, diffuse type is a little more common than in, say, Asian countries. This is going to present in younger patients, the mean age being around 40, and it's associated with genetic syndromes, specifically the loss of ECAD-herin expression, which is what kind of keeps cells together. So when these cancers lose their ECAD-herin, that's what allows them to spread more diffusely and make a diffuse type gastric cancer. Often the cardia and proximal stomach will be involved with this diffuse type cancer, so these are essentially always treated with total gastrectomy. Subtotal gastrectomy is generally not an option for a diffuse type. Intestinal type, so sort of all the opposite thing. So these are more well differentiated. They form glands and look more like a colon cancer under the microscope. They're found in the more high-risk areas, so again, the Asian countries. Found in older patients, associated with environmental factors such as H. pylori, smoking, high salt, and smoked foods. And they're found mostly in the distal stomach, so these can often be treated with subtotal gastrectomy. Interestingly, in the United States, as we've eradicated H. pylori, again, the intestinal type has become a little less common, the diffuse type becoming a little more common in the United States. The other thing to know here is that there are many papers that have documented that the outcomes of treatment of gastric cancer are better in Asian countries and Eastern countries. And there's always a question of whether that's because the surgery is done better, the lymph node dissection is done better, or just there's some inherent difference between gastric cancer in these Asian countries versus Western countries. And this, what we're looking at here, these different types of gastric cancer argue somewhat that there's just a baseline difference between gastric cancer in a Western country versus an Eastern country. So it's just something to keep in mind when you read papers from Korea or Japan. The patients that they have generally are going to present with more intestinal type and with earlier stage tumors than the patients treated in the United States. So just a quick kind of endoscopic picture to show you the difference between intestinal type and diffuse. So intestinal type, again, it's going to often be, one tumor that looks more like what you would expect a colon cancer or something like that to look like. You can essentially put your finger on where the tumor is, and you kind of know if you can get that out with good margins that you're going to have a good outcome. Whereas the diffuse type over here, you just see there's sort of erythema and blanching throughout the entire stomach, and there's no clear tumor that you could put a tattoo around. So that kind of gives you an idea that it literally is diffusely throughout the stomach. That's why it's called diffuse type. So just a few things on the genetics of gastric cancer and some of the predisposing syndromes that we need to be aware of. So the biggest one we need to know is hereditary diffuse gastric cancer. This is generally caused by CDH1 mutation. At least more than half of these are caused by CDH1 mutation. That's the one that's going to be on the test. So CDH1 mutation, this is a truncating mutation. Usually it causes loss of ECAD-herin expression, which again predisposes you to diffuse type gastric cancer like we talked about. Again, more than 50% are caused by these truncating CDH1 mutations. By the age of 80, patients with this mutation have an 80% risk if they're female, 60% risk if they're male of getting a gastric cancer. Average age of diagnosis is 37 years old, so these are young patients. They need gastrectomy between the age of 18 and 40 according to the recommendations. Some people have recommended endoscopy starting at the age of 18, but the problem is with diffuse gastric cancer, there's often not a precursor lesion. So these patients will go from having a totally normal endoscopy to having diffuse type gastric cancer in between scopes, and so generally it's just recommended to do a gastrectomy. If patients with this mutation, if they're female, also have increased risk of breast cancer, so they will often undergo prophylactic mastectomy as well. The ones that are not caused by CDH1 mutation, it's not entirely clear what gene causes them, but PALB2 has been implicated. I wouldn't worry too much about that, but just know that CDH1 mutation is the gene that you know for hereditary gastric cancer, and these people need prophylactic gastrectomy. Just other syndromes that can be associated with gastric cancer: Lynch syndrome, as you guys know, DNA mismatch repair genes. Colon is most common, endometrial second, but gastric cancer is the third most common in this syndrome. Juvenile polyposis syndrome, associated with SMAD4 mutation, 20% lifetime risk of gastric cancer. These patients get EGD starting in their mid-teens. They often have polyps all over, but gastric is one place. Peutz-Jeghers syndrome, on the test it'll have something about mucocutaneous pigmentation, and then GI polyps somewhere. Often they present with a GI bleed at a young age. These patients have a 30% risk of gastric cancer over their life. They get EGDs starting in their late teen years, every 2 to 3 years, depending on their polyp burden. And then finally, FAP, which is the APC gene on 5q. You guys should know that for the test. Know that for your ABSITE. Increased risk of gastric and periampullary polyps and cancer. So these patients will also undergo EGD starting around the age of 18. And they need to not only look at the stomach, but also at the duodenum and the periampullary areas. So presentation of gastric cancer, this is in your score objectives, but the reality is that there's no clear presentation. Often it's vague epigastric pain, not relieved by food. That's kind of the classic story. They can have obstructive symptoms if they have a distal lesion. They can present with gastric outlet obstruction. That's usually not a great sign. If you have such an advanced tumor that you have gastric outlet obstruction, usually don't do terribly well. Probably the most common presentation is a GI bleed or just iron deficiency anemia, kind of fatigue, and then they have positive fecal occult, get scoped, and they find a lesion. That's the most common, I would say, for intestinal type gastric cancer. And then, when you have a gastric ulcer and you treat it appropriately, you need to have a follow-up EGD 3 to 6 months later to make sure that ulcer resolves. If it doesn't resolve, it needs to be biopsied, and you have to start thinking that it's actually a gastric cancer. One presentation of unexplained weight loss and early satiety. This is generally a very bad sign, as it can be associated with what's called linitis plastica or Britton's disease. Linitis plastica means leather bottle stomach, so it kind of gives you an idea of what you're talking about. Linitis plastica is diffuse type gastric cancer that's infiltrating the wall of the entire stomach, causing the stomach basically not to be able to expand when you eat, and so these patients they just don't have much of an appetite, have early satiety, and they usually present sort of emaciated with a lot of weight loss. Again, this is an endoscopic picture of linitis plastica, and then a CT picture of linitis plastica. As you see, the entirety of the stomach wall is thickened diffusely throughout the whole stomach, not just at one spot like an intestinal type tumor. So again, just know that term linitis plastica associated with diffuse type cancer generally has a very bad prognosis, unfortunately. So diagnosis of gastric cancer: after you suspect it, you're going to get an EGD and do a biopsy. There's not a whole lot of fancy stuff with the diagnosis of gastric cancer. You just scope it and get a biopsy. The things you want to know on the scope: the location of the tumor, the endoscopic appearance. Often the endoscopist can tell you, well, there's clearly one solitary lesion there, or this looks more like a diffuse type gastric cancer, and that's going to affect a little bit of how you think about that patient's prognosis. And then from the pathologist, you can get that differentiation. Is this well differentiated? Is it poorly differentiated? And then the histologic type of intestinal or diffuse type. So a quick mention within the realm of diagnosis and where the tumor is, we need to be aware of these Siewert's classifications. So this is for tumors that involve the GE junction. This is a little more advanced for the interns. You probably don't need to know this stuff, but the more senior residents need to be aware of this classification. So these are tumors that involve the GE junction. The the location of the tumor, as we'll talk about here, is based on the epicenter of the tumor. So it's not the top end or the bottom end of the tumor. It's where the tumor is centered. So Seward type 1, this is essentially a distal esophageal adenocarcinoma, so classified as having its epicenter 1 to 5 centimeters above the GE junction. And these are essentially treated as esophageal cancer. So these should be approached with a thoracotomy, or approached basically as a distal esophageal cancer, which means that you have to dissect the high mediastinal nodes. Type 2, this is from 1 centimeter above to 2 centimeters below the GE junction. So these are true GE junction tumors right in the middle, right at the GE junction. These, it's a little less clear how you're going to approach it. Do you approach it like you would approach a gastric cancer, or like you would approach a esophageal cancer? Sort of depends how high the extension is. So there's data that if the tumor extends more than 4 centimeters up onto the esophagus, then there's a reasonably high chance of high mediastinal nodes. So you need to do you need to resect high mediastinal nodes, which typically requires a thoracic incision, so essentially like an Ivor Lewis. So those are going to be approached more like an esophageal cancer. And if it's less than 4 centimeters up onto the esophagus, then you can approach it just like a gastric adenocarcinoma through the abdomen with a low mediastinal node of dissection transhiatal. So after you do your gastrectomy, you just reach up through the hiatus and get those low mediastinal nodes. Again, that's 4 centimeters above. 4 centimeters above the GE junction is where that cutoff of risk of high mediastinal nodes starts to happen. Finally, a type 3. These are basically subcardial gastric adenocarcinomas. So you treat it like a gastric adenocarcinoma. You approach this through the abdomen. There is a risk of low mediastinal nodes if greater than 2 centimeters of the esophagus is involved. So if the tumor extends up on the esophagus 2 centimeters, you need to make sure to get those low mediastinal nodes, because there's a 10% chance of those being positive. The other thing to say on these, especially type 2 and 3, you do need to do a full gastric lymph node dissection, which we'll get into later. So the take-homes here: type 1 is approached as a low esophageal cancer, so you do an Ivor Lewis. Type 2, it depends. If there's more than 4 centimeters of esophagus involved, then you should do an Ivor Lewis. If not, then approach it through the abdomen. Type 3 is approached as a gastric cancer through the abdomen. All right, so initial workup and staging of a gastric cancer. You can do a history and physical like everybody else. We'll talk about a couple buzzwords to think about during your history and physical, especially for tests. You're going to get some labs, CBC chemistry. I would add pre-albumin to this because some of these patients will be rather malnourished, and you want to know that before you start doing anything surgically to them. You're going to get a CT chest, abdomen, pelvis on everybody. PET scan, basically the NCCN guideline says as indicated, so if there's questionable findings on the CT, you could get a PET scan to try to figure out what exactly is going on. EUS is the key for clinical staging of the clinical T stage and end stage, so everybody gets an EUS. If the nodes are more than 5 millimeters, they're considered suspicious, and if they're accessible, you should FNA them. If they're not, you may have to just presume they're positive. Staging laparoscopy. So this is one kind of strange thing on gastric cancer that you need to know. Everybody with a clinical T1B or higher, so essentially everybody who's going to undergo a resection needs a staging laparoscopy before you go for their resection. So you can do it at the time of the surgery if you're going to do surgery up front. Otherwise, you do it before you start any therapy, any neoadjuvant therapy. But anybody clinical T1B or higher needs a staging laparoscopy. And then finally, if they have metastatic disease, you're going to test for HER2, MSI, and PD-L1. That's pretty advanced. I wouldn't worry too much about this stuff. All right, so on the history and physical buzzwords for your boards, Virchow's node is an enlarged left supraclavicular node with any GI cancer, but can specifically happen with gastric cancer. Sister Mary Joseph's nodule. This is a periumbilical nodule that's from peritoneal spread, which again is very common with gastric cancer, so this is classically associated with gastric cancer. Irish node is an axillary node from gastric cancer. A Bloomer shelf is a drop met from an upper GI cancer, usually gastric, down into the pouch of Douglas, and it can be palpable on digital rectal exam, so know that one. Krukenberg tumor is a met from a gastric cancer to the ovary. So you should know all those for your boards. They seem to come up on the ABSite, etc. All right, so staging by EUS. Again, this is the mainstay of clinical staging. It's going to tell you your T and N stage. So we need to know how to interpret this endoscopic ultrasound. There have been questions on the ABSite where they just show you this picture and tell you where the tumor is and ask what T stage it is. So a T1 is going to be in the mucosa. So this first dark band is the muscularis mucosa. So you have the, so basically that goes from the lumen out to the end of this dark band. Next is submucosa. So the submucosa is this first bright band. This is an important point in gastric cancer, is that once you get to the submucosa, there's a lot of lymphatics in the submucosa, and so now your risk of lymphatic spread goes up to the point where you have to assess it. So a T1A tumor in the muscularis mucosa or in the lamina propria can be treated with endoscopic resection because you don't need to assess the lymph nodes. Once you get to a T1B, which is into the submucosa, you have to assess the lymph nodes, which means you're going to go for resection with a lymph node dissection. The next dark layer here is another muscular layer. So this is the muscularis propria. So that once you get into that real muscle, that's a T2 tumor. At this point, once you get T2 or above, or if you have nodal disease, then you start talking about multimodal therapy. These patients are going to need chemo or chemoradiation. We'll talk about that later, but just know these kind of important breakpoints. Once you get to T1B, they can't be treated just endoscopically. They need a lymph node evaluation. Once you get to T2, they can't be treated with surgery alone. They need multimodal therapy. And then finally, the serosa is the last white band. There is T3 disease, which is a subserosal, and then once you penetrate the serosa, you get into T4 disease. T4A is penetrating the serosa. T4B is getting into an adjacent organ. So that's EUS. Again, have a fair idea how to interpret the EUS of both the stomach and the esophagus, which is basically the same, except that the esophagus doesn't have serosa. So we're at about 20 minutes, so I'm going to stop here and call this the end of part 1. We'll pick up the management of gastric cancer in part 2.